Can you hear us? Abdelali, vous êtes ici?
Yes, I can hear you. This is Manuel.
Okay. Abdelali, vous pouvez m'entendre? Hello, everyone. This is Benjamin from the Collaborative Secretariat. We are about to begin. So I will first give the floor to Agnes Sokat, the Director of the Health Governance and Financing Department here in WHO. We will Agnes, the floor is yours.
Thank you, Benjamin. Good morning or good afternoon to those who have connected to this webinar, which will be focusing on the governance roles and capacities of Ministries of Health worldwide. And today will be part one, which is a practitioner's perspective. This is a webinar that is organized by the World Health Organization as part of our work on the Health System Governance Collaborative, together with the UHC Partnership, which provides support to countries on developing UHC policies and strategies. And today we're working with the Alliance for Health Policy and System Research, who has helped us develop a framework on the governance role of Ministry of Health, and we'll be presenting it today. So we are really delighted to have today Dr. Sheikh Kabir from the Alliance, who is going to present this framework. This is the introduction and the practitioner's perspective today. And later this month, we will have a second webinar, which will focus on an ethical perspective and the role of Ministries of Health in social justice. It's important for me to let you know that we will have a WHO working paper that will be released this month, which will be illustrating the framework that will be presented today, together with a literature review offering examples of challenges and capacity building experiences at country level, doing a systematic review of how Ministries of Health around the world have tackled this issue of governance, and how they're doing it in practice, and how they build their own capacity in this area. So Dr. Sheikh Kabir will present the framework, and then we will have two respondents from countries, from two countries that have very interesting experience on this issue, which are Morocco and the Philippines. So we will have Dr. Manuel Daret for the Philippines, responding and presenting his views on the working paper of WHO, offering its reflections on the relevance and possible applications of the framework at country level. And then we will have Dr. Abdelali Belghiti from Morocco, presenting his views on the framework and how it applies to the specific context of Morocco. Then we will have a discussion in which those of you who are online will be able to raise your hands digitally, and we can give you the floor, and you can ask questions to any of the three presenters, or to to the WHO team, including myself. So without any further ado, let me give the floor to Dr. Kabir Sheikh so that he can present the framework on the governance capacities and changing roles of Ministries of Health from the World Health Organization together with the Alliance for Health Policy and System Research. Over to you, Kabir.
Thanks, Agnes, for the kind introduction, and welcome to all participants. I'm going to start with the presentation right away to save time, since there's quite a lot to present, and we're looking forward to a vibrant discussion. So this is the title slide, and just take the opportunity to talk a little bit about why we decided to work in this area. And clearly, the issue of lack of capacity for governance among ministries of health is often advanced as an explanation for the failure of health systems in low and middle income countries. But we still lack a coherent and actionable understanding of exactly what constitutes these governance roles of ministries of health, and what are the type of capacities that they need to have in order to fulfill those roles, and also what is the kind of guidance that we could provide them to actually bring about improvements in those capacities. So that was the aim of this exercise, and for that we did an exercise where we drew on related existing frameworks of governance, but also more widely on the conceptual literature on health systems and health systems governance. Presentation is in three parts. I'll start with a very brief introduction and then move on to actually describing the framework, which is the main part of the presentation, and then briefly touch upon applications. We, as Dr. Suka referred to, we also undertook a literature review. I won't be presenting the findings here for want of time, but we look forward very much from we all know this. I think it's a truism. Things are always evolving, and and the role of ministries of health is no exception. So we know that ministries of health clearly occupy a very unique role in the governance of health. They've always had an exclusive constitutional or state mandated sort of a role over the subject. Their ministries are expected to provide, ministries of health are expected to provide direction and vision for the health system, and are central to regulation and also to managing essential public health functions. And at the country level, ministries of health can also share and coordinate their governance with other organizational actors, such as councils, agencies, and other subnational parts of federal government polity. However, in addition to that, we mentioned the role is evolving. Now they're not only expected to manage public services and institutions, but they're also proactively expected to exercise leadership in more complex, pluralistic, and multi-sectoral contexts, and also to be prepared for and to predict emerging and future challenges, and not just deal with current situations. These are this is a snapshot of some of these changing contexts and the demands on ministries of health that are evolving. And as we know that with this evolving context, the roles in governance are also not static. Major changes in the way that health services are delivered, organized, and managed. And there's also a rise of market-based health services, and many countries have also seen decentralization reforms that have created a new array, a new crop of issues for stewardship, leadership, and regulatory roles of ministries of health, as have other emerging challenges such as climate change, epidemiological and demographic transitions, and reduced aid budgets. So what do we know about the subject from the existing literature? What we know is that there have been different frameworks that have been proposed around health sector governance, and each of them have come to the problem from a different perspective, a different orientation. The different frameworks have had different lenses. Some are focused on responsibilities and tasks for ministries of health. Some have focused more on emergent and extant challenges and issues, and others have focused more on underlying principles and values for health sector governance. There's also an active literature on stewardship roles of ministries of health, which we also referred to, and that's a different perspective which focuses more on ministries' ability to manage in pluralistic environments. So within this literature on the existing ways of framing health sector governance and the governance roles of ministries of health, we've identified two key gaps: the need for a unified framework that brings together all these different dimensions, and the need for an actionable framework that can actually help with strategic development and benchmarking and further research. That brings us to the actual framework which we developed, and I'll introduce the framework, but first just to highlight that the definition that governance is a multi-dimensional process that encompasses formal as well as the informal elements. And in this framework, we make a particular point of distinguishing between what we call de jure governance processes, corresponding to the more explicit or formal stated governance roles of ministries of health, and other aspects of governance which we can call more soft or tacit aspects, which include their roles in response to contextual change, relationship management, and values management. We'll start with some standard definitions of some of the key terms. So capacities, a couple of definitions for capacities: the ability to carry out stated objectives, or the ability of an organization to function as a resilient, strategic, and autonomous entity. Governance, here is a WHO definition. Leadership and governance involves ensuring strategic policy frameworks exist and are combined with effective oversight, coalition building, provision of appropriate regulations and incentives, and attention to system design and accountability. And in addition to that, we also refer to a broader definition for governance: processes that are formally or informally applied to distribute responsibility or accountability among actors in a given system. And for us in developing this framework, it was very helpful to think about governance as a process. More on that later in the presentation. So this is the framework. I hope that you're able to see it. The text is a little bit small, but I'll also talk through the different aspects of the framework which might make it a little bit. 4 types of governance roles for ministries of health that are included in this framework. And you'll notice that each role on the left is linked to a key performance area on the right. And the 4 performance areas are implementation of de jure responsibilities, resilience and relevance, leadership and diplomacy, and values propagation and goal alignment. So among the roles, the first role is the de jure governance roles. So as we've already gone over, ministries have formal and sanctioned responsibilities over health, including a central role in health sector governance. And we also know that there's been a gradual expansion in these responsibilities in recent decades. In many low and middle income countries, the growth of domestic private healthcare sectors, the proliferation of donor agencies, and a recent focus on multi-sectoral action have expanded the Ministries of Health remit in stewardship, regulation, resource management, intelligence management, and the production of innovations. Ministries have the added pressure of these increasingly diverse tasks, despite staffing limitations and turnover, imbalances in staff skill mix, the demands of political leaders and international donors, and complex relationships with state and non-state actors at the national and subnational levels. The second role is preparation for and response to changes in context. We've already gone over some of the rapidly changing contexts, whether political, economic, ecological, or epidemiological, and these are increasingly a reality for ministries of health to deal with. Preparing for and responding to these changes represents an often unstated or tacit expectation of their governing responsibilities and need to be taken into account. So ministries of health are expected to navigate through mutable political climates to prepare for and tackle health and environment crises, adapt to economic and social change, and respond to global events and phenomena. One is relationship management. And as we know, ministries of health are expected to manage an array of relationships, both and outside government. Relationships have been described often as a spectrum involving control, coordination, collaboration, and communication in different manners. Each relationship is also characterized by its own political and power dynamics. Ministries of health must negotiate with other sections of government, convene and collaborate with a range of non-state actors, and manage regulatory relationships with stakeholders such as health professions or industries. And as we well know, the SDGs have also underscored the need for ministries of health to engage multiple sectors towards common goals. The fourth and final role is values management. And often the least explicit or least stated of the role of ministries of health is values management in instituting and managing processes that advance values and broader health and societal goals. Examples of these include processes to enhance accountability and transparency, increase efficiencies, and ensure participatory and inclusive decision making. Values are often seen as latent or amorphous or fuzzy and shaped by political, social, and organizational context. They've traditionally been regarded as being difficult to change and have not been the subject of explicit reform initiatives. However, distinct mechanisms to change, to manage, enhance, and promote these values can definitely be put into place by Ministries of Health, and several examples of that. That was a bit of a heavy slide, and I'm coming to another slightly heavy slide, but hopefully it will help us to understand what we mean by capacities in the context of governance. So what is clear is that all those governance roles that were described in the previous slide necessitate that Ministries of Health possess specific capabilities, capacities, or abilities to actually handle those roles. Capacity is required at multiple intersecting levels for a ministry to perform in a health system. And we refer to an existing framework, Potter and Brow, for health sector capabilities, which identified 9 categories for strengthening. But we drew on 6 specific categories within these to refer more closely to Ministry of Health governance dimensions. So these are structural capacities, which refer to the existence of appropriate decision-making forums, systems of record keeping, and mechanisms of accountability. Second is role capacities, which refers to whether organizations have been given the appropriate authority or responsibility to make decisions and to undertake functions. Third is personal capacity, which focuses on individual competencies, such as whether staff are sufficiently knowledgeable, skilled, motivated, and competent to perform particular duties. Workload capacity focuses on quantitative aspects of capacity, such as sufficient numbers of staff, existence of clear practical job description, appropriate skill mix, and so forth. Performance capacity refers to the resources, the tools, infrastructure, finances, equipment, and consumables that are required to undertake these roles. And finally, supervisory capacity concerns internal reporting and monitoring systems, accountability mechanisms, and availability of incentives and sanctions to facilitate the delivery of these functions. So these are the 6 types of capacities that are directly applicable to governance by Ministries of Health. And with this slide, we bring together the different governance roles that were described in the previous slide and the governance capacities that we just described. As you will see on the right-hand side, the framework comes together by linking the capacities required for each particular role to a performance area. And the attempt here is really to unpack the black box of what constitutes governance successes and failures attributed to Ministries of Health by differentiating the dimensions of governance and identifying them with a simple breakdown of categories of roles, capacities, and performance areas. And as you can see, this is not, this is a meta framework in that it would still require the development of a specific assessment instrument, which would be based potentially on the different categories outlined in this framework. So what are the uses, potential uses for this framework? So the uses include providing the basis for such mapping or that could take place by national governments, gap analysis for Ministries of Health, and the identification of specific actions to strengthen governance capacity. Another key application is benchmarking, especially for capacities that can be quantified or standardized, such as the very easy ones, per capita workload capacity, but also for others. The framework can also be used to conduct in-depth analyses of Ministries of Health governance capacities and as the basis for comparative analysis of governance roles and capacities across different Ministries of Health. And very importantly, to promote learning between them. Ultimately, we hope that the framework will drive not just further empirical study, but also the specific identification of capacity needs and capacity building efforts in the context of ambitious reforms of Ministries of Health and strengthening in the broader context of strengthening health systems and governance. That brings me to the end of the presentation. So thank you very much, and over to you, Ben.
Thank you very much, Kabir, for this excellent presentation, and thank you for already mentioning some of the necessary steps towards applicability. So to continue along these lines, I'm going to give the floor to Dr. Abdelali Belhedi, who was a former Secretary General of Health in Morocco. And he will start with some reflections on what's the relevance of that framework for practitioners' work and what might be some necessary steps to make it even more actionable. Abdelali, if you can hear me, the floor is yours. Ali, are you there? Ali? Okay, so while we sort out this little glitch, I will give the floor first to Manuel Derrit for the second reaction, and we'll come back to Ali after that. Manuel, I'm giving you now the right to share your own screen.
Thank you very much.
Okay, good.
I'm just about to share my screen.
Give me a sec. Okay.
Is that okay?
Now you should be able to do it, but you're not doing it right now.
I've already shared my screen. I have it. Isn't it showing?
Can you try again? We are not seeing anything.
Okay. Okay, let me do it again.
Okay, it's working. Thank you.
Okay, thank you. Good day to everyone, and thank you for this opportunity to make a presentation. I'll try to be brief. The Philippines is at the threshold of really a new beginning. It recently passed the Universal Healthcare Law in February 2019. And this law is a milestone which is the Filipino citizens are now covered by social health insurance. That was not the case before this year. And every year, people had to pay the premiums. And for the poor, local governments had to pay the premiums. And if they didn't pay the premiums, the poor would not be covered. It has been quite a journey to this milestone law. And in order to arrive at that, at this point, we had to undergo two massive transitions over the last 27 years, from 1991 to 2018. These transitions were actually initiated by legislation, and they required fundamental changes in the governance roles of the Department of Health and its capacities to undertake these roles. So for this presentation, I'm going to try to use the WHO governance framework as a way of analyzing what happened over the last 20 years. So in part one, I'm going to try to explain the two transitions, in this case, the decentralization in 1991 and the move towards social health insurance in 1995 to try to cover the country. In part two, I will try to offer insights relevant to the third transition, which is triggered by the new law in 2019. So just very briefly, something about the country. It's an archipelago, and you can see there's 7,000 plus islands, 2,000 of which are inhabited. And you can see in color here that there are 17 administrative regions in the country. Socioeconomic development is uneven across this region. On the average, poverty levels are around 20%. That's the national average. But in regions, poverty can be as high as 50%. So there are very many remote and areas in the country. So this can give you an idea of how difficult it is to cover the whole country with health services. So this is the first transition, and this is an organizational chart of the Department of Health. Where you see a dotted line, that is actually, you might say, a devolved segment system. So if you think of this of the Department of Health as being a central bureaucracy from top to bottom. Before 1992, you had the Office of the Secretary in charge of the whole system. In 1992, devolution or decentralization actually devolved health services to the provinces, and there were 76 provinces all over the country, to the cities, and there were about 30 chartered cities in the whole country, and 1,500 municipalities. So you can imagine that one centralized bureaucracy, all of a sudden, there were thousands of independent units that were now in charge of their healthcare. Each province had its governor and provincial health office, and they were in charge of the hospital system in the province. And I'm pointing that here, the provincial hospitals and the district hospitals. The city hospitals were in charge of their city hospitals, the city health offices, and their centers, their health centers, and the municipal offices were also in charge of the rural health units. So that was the first transition in 1992. The second transition in 1995 had to do with social health insurance. In 1995, a law was passed that said we are going to try to reach everyone in the population with social health insurance. But as you can see, line at the bottom here, coverage of social insurance per capita actually was, and in 2014, the percentage of social insurance of total health expenditure about 14%. That's about 500 divided by 3,500 pesos per capita. The target that was set in 1998, the reform program of the Department of Health, was 30%. So you can see how difficult it was to actually manage the coverage of social insurance for the country. Now let me give you some context about the decentralization, which I will explain further. You see, decentralization came about because the principal author of the local government code, a senator called Aquilino Pimentel, was a champion of human rights, particularly during martial law. And he believed that by providing local governments with autonomy, it would guard against the tyranny of central government, as experienced during the martial law years. So there was really a political basis for the local government code. I was a director at the 1991 when the local government code was actually passed, and it actually took the department completely by surprise. The health system was totally unprepared for decentralization and the devolution of health services to local governments. And therefore, the effects on the health bureaucracy were debilitating. Later, and this was sometime in 2015, 2016, an independent study to look at the 25-year assessment of the Philippine health sector performance was done. And it was by a group called UPICON, which is University of the Philippines. It was a consulting group. And in their study, they said an immediate consequence of devolution was fragmentation. Local governments operated and financed their own health facilities independently of other local government units. With administrative control of local health services now in the hands of the local government units, it became difficult for the Department of Health to provide technical supervision at the different levels of the local healthcare system, or to maintain a health information system for local and national planning, let alone implement national health policies. Given that, what I want to do now is the WHO governance framework as a tool of analysis to try to explain briefly what happened as a result of these transitions. Well, first, very clearly, the role of the Department of Health changed with decentralization, particularly the de jure government's roles. Because from a centralized bureaucracy, which really governed through service delivery as a centralized bureaucracy, it now needed to capacitate itself for broader policy development, strategic direction, and oversight of its partners, particularly in local government. But in retrospect, getting firmly into this changing role took many years. The health workers took time to adjust. There was a grieving process after the decentralization, and there was resistance within the bureaucracy to let go of the centralized power. And the devolved units actually were very angry at this decentralization because they felt they were just cut off. The Department of Health had to learn how to manage the new relation with local governments. New structural capacities, governance architecture needed to be built. And because of the grieving process and the anger within the devolved units, they even resisted giving information to the central office as a result of their anger. Thirdly, not enough money to actually drive performance capacity. For example, not money from central government flowed to the devolved units. Therefore, provincial hospitals, district hospitals were neglected. There were shortages in personnel, affecting personal capacity, particularly in devolved health facilities, especially in remote and rural areas, prompting the Department of Health to actually start deploying nationally funded personnel to these areas. Attempts, for example, at the local government level, new governance structures failed. For example, municipalities had to band together to support their district hospitals. But because they were autonomous units, they refused to come together. It was very difficult for that, particularly if they felt that they had to compete money, which they felt they didn't have, and they had other priorities. And finally, the Department of Health had no direct supervision over the municipalities or the municipal officer, who was now under the supervisory supervision of a political person. And if the mayor had no priorities for health, the municipal health system was stuck. So when you think of that transition, the decentralization, coupled with the transition of trying to cover the country with social health insurance, which was really the two transitions that the Department of Health, as well as the newly created Philippine Health Insurance Corporation was trying to do. You could see that the governance roles and the governance capacities were very much in array during these years. What I will show you next are some of the slides that, as a result of the 25-year assessment, showed how the health outcomes actually fared. This shows you infant and neonatal mortality rates from, in this case, 1980 all the way to 2014. Note that the evolution was in 1992, and shortly after that, the social insurance system law. But note, infant mortality rate plateauing at around that time and going flat. We know that infant mortality rate, its causalities are multifactorial, but certainly as a result of the assessment, we say that this was considered one of the structural weaknesses, the decentralization. This is a slide on maternal mortality ratios. And if you look at it, it compares Indonesia in orange, Malaysia in green, the Philippines in light blue, Vietnam in purple, and Thailand in gray. And look at the line of the Philippines here. It's remained flat for 30 years. So this is, again, we think, one of the outcomes of, you might say, this failure of effective governance during this term. And finally, if you look at life expectancy, and again, look at the Philippines here in yellow, you see in life expectancy with its neighbors at this point in 1985 to 1990 was in the neighborhood of 6, but sometime later, in 2015, it had widened to about 7 or 8 years. So you can see how, I would say, the governance processes at that time actually had a key role in these bad outcomes. But lo and behold, this year, we now have a new law, care law. And it says that now everyone is covered. And the problem is that everyone is going to win. All of the stakeholders, from the patients, the payers, the providers, the physicians, and the suppliers, they're all going to win. That's the promise. That's the promise of universal healthcare. The law is very comprehensive and very complex. And let me explain that just a bit. Will the universal healthcare law enable effective governance? These are just a few of its provisions. The law is a way of going around the decentralized system by clearly stating that the anchor for healthcare delivery will be the provinces and the cities. What that means is now the governors and the mayors will be given as well as the mandate to run their health systems in a way that they can, private sector, develop new relationships, health provider networks, and manage it so that they can combine individual care with population-based care. This is an example. This is the budget at the Provincial Health Office. As a result of the devolution, the provinces really didn't have any money. This new law creates a special health fund that will allow national government, Department of Health, PhilHealth, to provide services, funds to this special health fund, which now the city or the province can manage to pay for their system. And these are the components of the system at the provincial, the city, and the municipal, to pay their private providers, as well as to implement population-based initiatives. The law also mandates that PhilHealth change its role from being simply a reimburser for health services, but a strategic purchaser of health services, thereby setting the priorities for what they're going to purchase, accrediting the health service providers more effectively than they were doing, and also determining how services are going to be purchased. Note that all of these new roles are going to need very, very new capacities. How quickly will these capacities be developed? We're given 10 years. And for example, the law actually states that it's going to put a fundamental emphasis on primary care. Therefore, how soon until new capacities to upgrade primary care facilities are put in effect? How soon can primary care providers fit for purpose be developed so that they are multiplied all over the regions and are able to increase the ratio of primary providers per population? This is something that the whole system has to address. So having said that, this is an example. Note that over the years from 1995 to 2015, and these are the rural health units, which are the primary care facilities in the private sector. Note the comparison between blue and orange. The ratio of RHUs, the rural health units per thousand population. The ratios have actually dropped. They were higher in 1995, and they were much lower later. And therefore, this is certainly one strategic area that needs to be addressed. if you are to strengthen primary care in the system. So I'm going towards my last slide. Universal coverage now of social insurance is 100%. We have to define the service coverage, the services that will be covered over the next few years. At the moment, only inpatient services are basically covered by social insurance. We need to develop a more comprehensive package that includes primary care. And of course, by 2030, we hope to be able to do better financial coverage of hospital bills. These are very, very big challenges that the country is facing, but I think there's new hope. What has happened over the last 25 years is that we've gathered more experience. There is a new crop of local government officials that are now in the provinces, in the cities, and they are now more aware of their responsibilities. The private sector is willing to participate with government in order to cover services for the population. But all of these details of contracting the private sector, developing the health provider networks across both public and private sectors, all of these need to be built. And I would say that this tool, this WHO framework, can help think through strategically what needs to be done. So this is my final slide. It's a quote from the paper. It says, Ministries of Health typically undertake an array of de jure roles, and these are some of them. Certainly, in the next years ahead, the Department of Health would have to be very clearly state that strategic vision, which in a sense has been stated in the law, but this now needs to be operationalized. There has to be balancing between the centralized and decentralized authority for decision making. Again, something that we've been working on, and we hope that we can do that better in the next 10 years. And of course, do the other things that are necessary in order to make the health system work. So thank you all very much.
Thank you very much, Dr. Derid, for these illustrations of how Ministries of Health have to adapt to changing roles, and maybe some hints on how to use the framework that was described by Kabir in a actionable way. We're going to go back now to our second invited response by Dr. Belriti. Dr. Belriti, can you try to speak, please? Okay. Dr. Belriti? We are please.
Hello?
Yes. Dr. Belriti, you are now on, so people can hear you. Can you just please can you mute the sound from your computer, please? Dr. Belriti, pouvez-vous couper le son de votre ordinateur, s'il vous plaît?
Hello, everyone. Do you hear me?
Oui, Dr. Belriti, oui, on vous entend. Est-ce que vous pouvez éteindre le volume de votre ordinateur, s'il vous plaît?
It's okay?
C'est bon.
Okay. Hello, everyone. Excuse me for this technology. First, allow me to thank you for your kind invitation to participate in this webinar about subjects that corresponds to brief Ministry of Health, particularly in low and middle income countries. Indeed, in these countries, health ministers must restore trust with population, staff, and partners. Please, next slide. ministry is perceived as a set of procedures and statutes. Framework according to its specificities, according to its is perceived as a set of specific roles and capacities. Straightening this for me of Ministry of Health is a major prerequisite, I think, for the health system's development, because it conditions both the effectiveness of its actions and the improvement of the health system performance. Personally, I held decision-making roles for nearly 20 years within the Ministry of Health of Morocco. And this is the first time that I come across a structured document that sheds light on the backlogs of the Ministry of Health and provides an alternative framework to traditional political administrative approaches. As just presented by Mr. Kibir in first presentation, the framework, next slide please. As just presented by Mr. Kibir, the framework for Ministries of Health governance includes 3 nested blocks. First block that corresponds to the governance roles of the Ministry of Health. Second block that corresponds to the operating processes presented here in the form of capacities. And the third block that corresponds to the governance functions of Ministry of Health. In my opinion, the proposed framework has some general and specific particularities that make it more relevant and appropriate for improving the governance of Ministries of Health. Slide suivant. Next slide. Regarding the general particularities, my analysis allowed me to distinguish 6 following observations. First of all, the governance capacities framework allows the analysis of a Ministry of Health not as a legal entity or as a government department, but as a portfolio of assets composed of resources and capacities. This new framework can be considered as an instrument to create coherence in the actions of the Ministries of Health and enable an easy positioning of the stakeholders. The framework also offers an alternative to the bureaucratic view of public administration by presenting the Ministry of Health as an instrument or lever of action for politicians to act and turn their decisions into results. In addition, I consider that the adoption of this alternative framework can be seen as a starting point for modernizing the health administration and optimizing the use of health resources. Another particularity of this framework is its 3-block design, which offers a triple referential subframes on roles, governance roles, capacities, and governance functions of Ministries of Health. These subframes allow for a multitude of analysis possibilities. Each block and on the relationships that unite them. Finally, using the capacity-based approach, this framework gives a pragmatic scope and research perspectives for health organizations in general and for Ministries of Health in particular. It can be achieved by taking advantage of all management tools related to this approach, like those developed in strategic analysis. Next slide, please. In addition to these general characteristics that I have just presented, relevance of framework become more obvious when considering its specific aspects. I say that the proposed framework allows us first to value the Ministry of Health. The proposed frame doesn't assimilate the Ministry of Health with an administrative machine, but with a set of roles, abilities, and skills. It also values the permanent staff of the Ministry of Health and acknowledges their different abilities and skills. The framework allows also to distinguish between the Ministry of Health and the political actors. Indeed, the proposed frame gives the Ministry of Health a proper role, independent of ministers. The ministry, like I say, the ministry is not the minister. The Ministry of Health is an inimitable set of capacities based on know-how that is part of continuity. Whereas the minister is a political actor who drives actions and changes and who can be a mobilizing leader. The framework can also be a transparent and deliberative instrument in multi-party context. Next slide. In addition, the proposed model provides framework of the strategic analysis of Ministries of Health for assessing the level of maturity of their capacities, thus facilitating the development of capacity building programs. Finally, the framework can also be used as a guide for the development of real laws and regulations to deal with the mission and organization of Ministries of Health. Otherwise, despite these elements of relevance, I think that the governance framework gain further relevance and appropriation must make some adaptations. For me, these adaptations concern the following points. First, I think that the 6 Ministries of Health capacities can't be systematic for all ministers and all countries, knowing that their stories, their context, and their environments are not the same. I propose to distinguish between common capacities that will be observable in majority of contexts and specific capacities that will be more contingent. In the same way, the Ministry of Health capacities don't all have the same importance and the same weights for the governance of Ministry of Health. I think that we need a tool to identify among all capacities those which are relatively more important. We can call them strategic capacities. This kind of capacities can be targeted by capacity building program to support possibly health reforms. Next slide. I think also some denominations of Ministry of Health capacities must be adapted. The notion of performance capacity, whose description creates a confusion between tangible and intangible resources. Both types of these resources are needed for Ministry of Health and for its performance, but the abilities are more valuable because they allow us to make better use of tangible resources such as human and financial resources. I think it's better to propose another name for this capacity or better describe its content. The problem also arises for the notion of role capacity, because through its title, this notion refers to ability of the Ministry of Health to fulfill its roles. That assumes that these ministries' roles are known, but often it's not the case. Reading the description of this role capacity in the documents, I consider it rather positioning capacity, which more reflects its role of coordination and alliance with stakeholders. Moreover, in section 3 of the documents on experience of countries, the document refers to this capacity not as a role capacity, but as positioning capacity in the face of the change of national context. For these reasons, I think that the notion of positioning capacity is more adapted and flexible. Next slide. Now, what's about the capacities of the ministries' decentralized entities? Ministry of Health comprises 3 entities: central administration, decentralized services like district and region, and public agencies. I don't know if the 4 roles and 6 capacities of Ministry of Health in the framework concern all these entities. I think that it seems more adapted to the central administration of Ministry of Health. Next slide. Regarding to its specific applications, I think that the proposed framework could be used to guide the development of regulatory texts like laws on the missions and organization of Ministry of Health, and to identify the strengths, weaknesses of the Ministry of Health and its missing capacity. It can be used to analyze the functioning of the central administration of Ministry of Health and to analyze the level of achievement of governance functions. The framework can also be used to facilitate the development of capacity building strategies for the Ministry of Health and to guide the development and implementation of a training plan for Ministry of Health staff. Next slide. Finally, to facilitate the use of this new framework, it would be useful to develop a practical guide to transition from the political administrative approach, traditional, to the capacity approach promoted by this framework. Develop also a tool to assess the strategic dimension of the capacities of the Ministry of Health as exists in the field of strategic analysis classic, and to elaborate a methodological support for the development of Ministry of Health capacity building strategies. It should also be said that the development of researches on capacity-based approaches in health organizations would allow better dissemination and application of the framework. Thank you for your kind attention.
Thank you, Dr. Belghiti, and thank you, Dr. David, for your 2 very interesting presentations that highlight very different questions about the framework and its applicability. In a second, we're gonna open now the floor to questions from the attendants. So if you have questions, please raise your hand digitally so we can give you the floor. We already have some very nice questions on the chat regarding both next steps for the framework and also regarding the Philippine example. while you decide of the question that you want to ask to our panelists, I'm going to first give the floor back to Kabir to maybe address the two examples that were and a few of the points that were displayed in the two presentations. Kabir?
Thank you, Ben. I'll keep it very short because I think the focus should be on getting the responses from the audience. I just wanted to thank the two panelists for their insights on the framework and also linking it to their very extensive and real-world experience of situations which require greater capacity of governance by Ministries of Health. I thought both sets of comments were incredibly insightful, and I particularly welcome the view of seeing Ministries of Health as assets compared to very tangible resources and capacities. I understand that in future, the health financing and governance team is going to look including, but that would also help to elaborate this understanding of the approach and of the framework. Certainly, we also appreciate the feedback very much on taking it to the next. I agree that that would be an excellent development. The key point that came out from both presentations for me was around decentralization and how we interpret the framework and apply the framework in the context of increasingly decentralizing in many low and middle income countries. And I think this is going to be a key axis of analysis which will intersect with this particular one. I understand there's also been work on decentralization, conceptual work on decentralization that has been done separately. And it will be very interesting to see the interlinkages with that. So certainly I welcome a more perspective on decentralization, and thank you very much again to panelists for those inputs.
Thank you, Kabir. So I'm going to first give the floor to Gift T. Shareka, who has a question. Gift, can you hear us?
Yes, I can hear you. Thank you so much. I wanted to find out if we can have a some sort of a copy of this proposed framework. It looks quite interesting, and I like the elaborate presentations done by the two presenters. It's quite clear and it's quite interesting. So I wanted to find out if we can get access to the framework.
So I'm going to take this one. First, as all webinars that are co-organized by the collaborative, the recording and the slides will be made available on our website. As for the framework itself, it was developed as a commission work by the collaborative, and it will be released as part of a WHO working paper later this month, coupled with a literature review that will illustrate some country examples of governance challenges and of capacity building that kind of illustrates the framework that was developed. So yeah, you will all have a chance to go much more deeper into those framework and its applications.
Thank you.
Okay, sure. Thank you very much. I'm now going to give the floor to Gelan Mohammed. Hello.
Hear me?
Absolutely. Go ahead.
Thank you all for your fruitful presentations, and it's such a pleasure to be in a webinar with all of you. My question is regarding youth. Those students or even like the NGOs of youth like IFNSA, IPSF, are they part of the success of the governance? Are they part, how can they take part with the ministries and help to improve such objectives? Thank you.
Thank you. I'm going to take a second question, and then I'll give the floor to Kabir to try to provide some element of answer.
The panelists can also
and also the other panelists, of course, yes. I'm going to give the floor now to Nadej Ad, who has a question. Nadej, can you hear us? Nadej? Hello? Okay, so I will come back to you in a second. We also have Mohammed Taranu, who has a question. The floor is yours. Mohammed? Okay, So I'm gonna just also go back to some questions that have been asked on the chat, and then give the chance to Kabir and to Manuel to answer those questions. So first, there's a question from Ciel Hadley he had a question for Manuel that said, thanks for this very interesting presentation on the Philippine example. And he thinks that the experiences with the devolution process is really fascinating. However, the international comparisons also suggest an interesting question. Why is that devolution in the Philippines was damaging to the trajectory in health outcomes, while it did not have such an impact in Indonesia? At least using your figures. So what was it about devolution in the Philippines that was different, and what did they get right or the Philippines got wrong? So I'm going to give the floor now to Kabir and then Manuel to provide some elements of response.
Thank you, Ben. I'll respond to the question on engagement of youth, which is, in my view, one of the communities that increasingly there's an expectation from Ministries of Health that should be engaged. I see this both as a specific expansion of the expected function of Ministries of Health, and rightly so, I might add, not just by happenstance, and also one of the underlying values in terms of creating the more participatory and accountable forum. So certainly, I think with the opening up of ministries and of governments, there is an increasing emphasis on the engagement of different segments of the population and of communities, and youth is certainly one of them.
Thank you, Kabir. I'm going to turn now to Manuel to answer the question about the Philippine example and devolution. Manuel, the floor is yours.
Thank you. Thank you for that question. I'm not quite sure exactly what year Indonesia devolved, but I know for sure that Indonesia actually consulted the Philippines in terms of their experience with decentralization. And therefore, I think Indonesia actually learned from the Philippine experience. With regards to the Philippines in particular, I think that the main reason that we didn't manage it very well, where, number one, there was really very little preparation for it. And when I say little preparation for it, I mean both the psychological preparation as well as the logistical preparation. I was there, and I saw it being implemented. And there was really not enough time for people to think through what exactly needed to be done. And there was nowhere where we could look for examples to emulate. And therefore, I think that was the main reason. It was a human factor that actually made it so difficult in the Philippines. But that is in contrast to the situation now, after 25 years. Because with the passage of the law, despite the fact that it's quite complex, I think the country and the health sector is much, much more attuned to the changes that need to happen. And while there's continuous debate on how these changes are going to be made, I think that there's much, much more willingness to embrace the change, in contrast to what happened in the 1990s.
Thank you very much, Manuel. I'm now going to give the floor to Eric Nyombeda.
Yes, thank you very much for the nice presentations, and also give me an opportunity to participate or to be an attendee in this web seminar. Now, I've listened to the presentation from Philippines and the good examples they have given. Now, what I didn't get from all these presentations is how this framework will help to address the problem of corruption in the low and middle income countries, which, as what I can see from Kenya here, is a threat to universal health coverage. I'm asking that question because I reside in one of the devolved units in Kenya where in Kenya where UHC had been piloted some few months ago. And from what we as lay citizens hear is that the indicators of particularly the maternal and child health might go low because the money that was supposed to be used for hiring health workers and things like that, additional health workers to support the program, did not do so. So I just wanted to ask the panelists how actually this framework can address the issue of corruption.
Thank you very much, Eric. How can the framework address corruption? It's a very good question. I'm going to take a couple more questions from the floor and then give back the floor to the panelists so they can answer. First, yes, for those of you who have asked their question, can you please unraise your hand so it's easier for us to manage? I'm giving now the floor to Ricky Liu, who has a question. Ricky, can you hear us? Ricky? Yeah, you here? Okay, so we're gonna try to we're gonna come back to you in a second. We're gonna give the floor to Swati SB. Swati, if you're here, you have the floor. Hello? Okay, so it doesn't seem to work. I'm gonna take another question from the chat and then come back to the panelists. One question that was asked is that was what are by Omnia Hamza. She was asking what are the most appropriate strategies to strengthen the relationship between the national, local, and federal government for decision making in the health systems using this frame. I'm gonna give that question actually to maybe Dr. Belriti, who also introduced these notions of decentralized different application for different levels of governments. Dr. Belriti, are you still here?
Yes.
Yes. So, la question qui vous est posée est comment renforcer la relation entre les niveaux nationaux, locaux et fédéraux, notamment pour la prise de décision, en utilisant ce cadre d'analyse.
Merci. Vous permettez que je réponde en français?
Je traduirai.
D'accord. Donc, moi déjà, je pense que le cadre de référence, il est plutôt adapté à un niveau central, là où il y a le plus de prise de décision. Et ce n'est pas une critique, c'est plutôt quelque chose qui va nous permettre de le mettre en application plus rapidement. Tel qu'il a été conçu, il est fait pour une forme standard de décentralisation. Maintenant, pour le niveau fédéral et le niveau décentralisé, moi, je pense qu'il faut profiter de la réflexion. Pour le niveau fédéral, déjà, il est plus facile parce que les décisions qui sont au niveau fédéral ne sont pas nombreuses. Donc, l'idée pour ce niveau, à mon avis, c'est de créer un lien, une alliance ou un lien de coordination entre les ministères non fédéraux et le ministère fédéral sur des questions thématiques. Le fédéral, généralement, n'a pas le pouvoir sur toutes les thématiques en rapport avec les décisions du ministère de la Santé. Donc, il faut créer une coordination thématique liée à un niveau supranational qui est éventuellement le fédéral. Par contre, pour les niveaux infranationaux, notamment le niveau district et région ou autre appellation, moi je pense le modèle ne s'applique pas nécessairement parce que déjà on parle de gouvernance et ces niveaux ne sont pas des niveaux de gouvernance. Donc il faut, je pense, réfléchir à une nouvelle façon plus souple de décliner ce modèle à un niveau déconcentré pour permettre ce prolongement entre la conception de la gouvernance selon ses capacités et leur déclinaison au niveau déconcentré. Moi, je pense que les niveaux districts et régions seront, je pense, très intéressés parce qu'ils sont sur le terrain, ils ont besoin d'être valorisés. Ils seraient très intéressés de s'inscrire dans un cadre comme celui-là, à condition qu'ils soient plus adaptés à leur niveau de décision.
Merci beaucoup, Dr. Belriti. So Dr. Belriti was saying that for this question of how you can strengthen the cooperation and for decision making between the three levels of government. This tool, as it was conceptualized and as it is right now, is not the best tool in the sense that it's more adapted at the central level where the decisions are made. However, the local government level should be conceived as a continuation of the central administration, and maybe a declination of that tool in a more flexible way could help the decentralized level interact more with more consistency with the central level. There's a few other questions from the floor. I'm going to go back to Eric's questions on corruption. Maybe Kabir, you can take this one.
Sure, Ben. So I think I should acknowledge also my co-author Veena Sriram, who was worked with me on the conceptual framework. And in some of the choices we made around what elements to include in the those functions that were explicitly or uniquely the role of Ministries of Health versus what constitute government or governance roles for broader government. And corruption explicitly is, of course, not unique to the health sector, but regardless, it is well addressed within the component or the role on values propagation and accountability, transparency within that domain, and also as part of the efficiency processes, it does get covered. So it's a cross-cutting role for Ministries of Health, certainly, and it is addressed through the framework, but it would be good to see its further elaboration as we move towards instrumentalizing the framework.
Thank you, Kabir. So Ricky, Svati, and Nadej had questions, but their connection was not so good, so they wrote them to us directly, and I'm going to read them in a second. First, I'm going to give the floor to Paul Marsden. Are you here? Oh. Paul, I think we can hear you. Okay, so I'll come back to Paul in a second. So first, the question from Nadej.
Hello.
Oh yeah, Paul. Here you are.
Hi. Sorry. I didn't know my microphone was on. Yeah, no, they were great questions. Sorry, I picked up a little bit into the presentation, and really, I was interested in learning a little bit more about this framework and really what's this saying, and how can we maybe look at this a little bit differently for helping us to address issues around, more sort of issues around accountability. We see a lot of these approaches, frameworks, tools, etc., for strengthening governance and leadership. But really, I'm particularly interested in the so what part of this. How can we then use this to try to help us ensure more accountability for decisions? Really think about the whole aspect about trying to build and enable a critical mass of managers that have those right skills that can apply those in the right ways, particularly when we start to see more of an emphasis around trying to strengthen decentralized management in different contexts. So that's what I would be interested in learning more of. Thanks.
Thank you, Paul. I think that really relates to the question from Swati. So I'm going to read her question. It said, where does willingness and values of individual ministers get captured in the framework? I ask this because though I understand there's a difference between minister and ministry, they are interlinked. And her second question was, is social accountability a part of values? And should it be insisted in every ministry, irrespective of the context? So first, I'm going to answer maybe a bit of Paul's question before I give back the floor to the panelists. And maybe Manuel, we haven't heard from you in a while, can jump in. So regarding accountability and how to make the MOH more accountable and values management, I think to the question of what do we do from here. So I think Kabir mentioned that this was a meta framework, but it had to be adapted to be actually usable and actionable for practitioners in the field. And I think that was also reiterated by both Manuel and Dr. Belriti, who really insisted on the fact that it had to give way for appropriation by practitioners. So the first thing that we did was ask some practitioners, such as Dr. Belriti and Manuel Derit, for their feedback on if it was of interest to them. Second round of work on this framework dissemination and talking with all of you today, and your feedback is very interesting, very welcome. We'll have some more session for people to be able to interact and give their sense on how it could be more applicable and how it can help accountability for MOH. And we plan with the collaborative to try to have some field testing in the next year and see how we can adapt the framework to the actual practice of governance and make it relevant for practitioners and for accountability. Manuel, you also want to jump in on those questions?
Yes, I would actually go back to what Kabir said initially, where when they conceptualized the framework, they tried to unify a lot of concepts, particularly those that had been already, you might say, described in the literature. And also, so they wanted a unified framework as well as a operational framework. And in this case, I would stress the operational part. Because from my perspective, and having used this, very, very superficially for now, to understand what actually went on with our devolution process, it actually helped me with levers for this analysis. And I think the objective of this framework is actually to disseminate it widely so that everybody, you might say in the health sector, can use this as a unified framework. And therefore, they would actually be very transparent with each other in terms of analyzing what's wrong with the system and what's right with the system. And they would be speaking the same language. And if they were in central government or if they were in the devolved system, they could, for example, talk about all of these capacities that needed to be built. They could talk about the roles and what roles they had to share. And I think this would be very helpful in terms of bringing people into the same conversation. So I think this is going to be the power of this framework, that ability to draw people using a common framework that is simple enough to describe, not so complicated so that it's very abstract, and it's very operational.
Thank you very much, man. Yeah, it's very, very relevant what you're saying. I'm going to take a last round of questions, and then we'll have to close the session, but I want to thank you for all your excellent questions. I have first a question from Nadej, directed at Dr. Kabir. So the framework was developed from a practitioner's perspective. Were inputs and comments obtained from practitioners in MOH in developing countries to develop this framework? And secondly, the purpose of the framework is to support countries in their health systems reform initiatives. Can this be done through capacity building? And when we clearly know that reforms are a political issue, with vested interest involved, and as such cannot be rendered technical. So that's one question. Then second question from Rick was essentially wondering about metrics for assessing implementation of that framework. And one last question I'm going to take from the floor is also from Sylvester Adeyemi from the International Pharmaceutical Students Federation, who was asking, what role has system monitoring played to ensure quality of services in primary healthcare at local levels in Philippine context? So question for Manuel. Maybe I'm going to start with this one, which is specific to the Philippine context, and then go back to Kabir to answer the last questions. Manuel.
Well, I think the question has to do with what's the use of this framework for primary healthcare in the country. Am I correct in understanding that?
The question from Sylvester is, what role has system monitoring played to ensure quality of services? So I think it's very much a question of what happened, not directly of the framework itself.
Oh, system monitoring. Yeah. Well, I guess this is one of the things that we have to fix. Because in order to monitor the system properly, you have to have the same type, you have to have information flowing through the system and everybody having access to it. And as I mentioned earlier in my talk, as a result of the problem with governance and the fact that it's fragmented, the information didn't flow to the system effectively. For example, now it's still a very one-way flow of information. People from the devolved sending information up to the central level, They're not using it as much in their devolved system to analyze what they're doing and so on and so forth. So I think the challenge for system monitoring is actually strengthening the flow of information through the system. And in order, I think you would have to strengthen a lot of the governance roles, particularly the jure governance processes that would include the gathering and the analysis of data. And this has to be done seamlessly across the system, particularly now that you have social insurance coverage. So there has to be an information system that covers all of that. Social insurance coverage that provides services to hospitals, to health centers, as well as population-based information about what's happening in the populations. All of this have to be there seamlessly within a system that everybody can look at, everybody can share, and everybody can have a conversation around.
Thank you, Manuel. So now I'm going back to Kabir for responding to the last questions and some closing remarks.
Thank you, Ben. I think it would be great if we could get closing remarks from the other panelists, actually, because I will try and respond to one really insightful question that, and I hope I'll address it appropriately. So the first was a simple question on whether we took inputs from practitioners, and we did. I mean, there were several rounds of inputs that we got from a number of policymakers and practitioners in the process of developing the framework. But we also recognize that since this is not a hard science, it needs continuous iteration and development, and at some point it was never going to be a perfect tool because it deals with real social and political realities. And as many highlighted, it's really important to put and really where we learn. So in that vein, it has been structured, I understand, by a working paper and not as a definitive piece of guidance. But we still hope it will have utility. So certainly this process again is another from people from the field, from practitioners and policymakers, and continue to improve it. So there is definitely the intention to do that, as well as the processes. On the other point on whether capacity development can ever be considered a technical process, as opposed to when we consider all the different political economies of what goes into the workings of ministries, and I actually I think that's a really good question, but I would actually like to flip it back, and I think that there's actually a very distinct role for making capacity development, articulating it as technical capacities, and that includes technical capabilities, rather specified capabilities to deal with political issues as well. And this is why very specifically we've included an explicit focus on the roles of Ministries of Health that are not just the mandated and de jure and written roles, but also the asset and softer roles around relationships management, values propagation. So just in closing on that, I think there is a definite role for specifying that are required to build those softer skills, and that gives people within Ministries of Health the potential to deal with political realities as well. Thank you, Ben. And over to the other.
Yeah, thank you much, Kabir. Dr. Belriti, I'm going to you now for closing remarks. Are you here?
Yes.
Yes.
Allô?
Oui, Dr. Belriti, vous pouvez parler.
Ok, je parle encore une fois en français. Hein?
Très bien.
C'est bon? D'accord. Déjà, juste les commentaires de M. Kébir, et je pense que dans la diffusion et la mise en œuvre de ce cadre de référence, il ne faut pas vouloir aller dans tous les sens. Je pense qu'à court terme, moi personnellement, façon de faire. La première, c'est élaborer déjà un programme de renforcement des capacités sur la base de ce modèle et accompagner certains ministères de la Santé pour renforcer leurs capacités et tester la force de ce modèle. Donc ça sur le plan des capacités. Une deuxième façon pour tester la force de ce modèle, c'est de le faire au regard des efforts actuellement pour développer la couverture sanitaire universelle. Ça veut dire construire sur ce modèle et accompagner d'autres pilotes peut-être, pour voir dans quelle mesure le renforcement de ces capacités leur permet de mieux avancer dans l'atteinte de la couverture sanitaire universelle. Une dernière observation, il est en rapport avec le contenu du modèle. La gouvernance rôle, il est lié essentiellement aux politiques publiques, à la définition des politiques publiques. Or, la manière avec laquelle les politiques, les constitutions et les règlements définissent les rôles des ministères n'est pas nécessairement conceptuel. Donc, il y a peut-être un rapprochement à faire entre les aspects conceptuels de ce bloc sur la gouvernance des ministères de la Santé et la discipline des politiques classiquement enseignées dans les différentes universités.
Merci beaucoup, Dr. Belriti. Thank you, Dr. Belriti. So, Dr. Belriti's closing remarks after Peter is the fact that he agrees with most of Kabir's comments, and that in the short term, application of this framework should be focused. And he proposes two ways of doing that. First, design a program for capacity building that you could field test with some Ministries of Health. The second would be to select some pilot countries and try to focus on those efforts toward implementation of UHC and try to monitor using this framework how does capacity building for the MOH in the road towards UHC. A final point that he wanted to make was maybe a way to drawing a parallel between the role capacity in the framework and public policy formulation as it's taught in most universities. Thank you, Dr. Belriti. I'm now going to go to Manuel for his closing remarks.
Well, thank you very much for this opportunity. I think as a final comment, I'd like to say that I appreciate this framework. For now, for its ability to help us analyze what has gone on in our own system. And I think other ministries can actually see how useful this tool will be. I guess what I'd like to emphasize is really we have to understand the human factor that goes on behind a framework like this. And it's not as mechanistic as just pointing out personal capacities or, for example, performance capacities. We have to understand also the psychology of the people within the organization and within the populations that they serve. And this framework has to be applied with that distinct understanding that we use it within a very, very human system. And therefore, we have to understand how cultures and how bureaucratic processes actually function in order to be able to apply this WHO framework more effectively. Thank you.
Thank you very much, Manuel, for these closing remarks. Thank you, Dr. Belriti. Thank you, Dr. Sheikh, and thank you, Dr. Sukat, for all your excellent presentation and answers. And most of all, thank you to the attendants who joined us for this session. I just want to remind you that both the slides and the recording from this session will be made available on www.govcollab.org. And encourage you to register on that website so you can continue interacting with our product, some additional feedback. This was the first part of a webinar series around this framework and how it can be useful from a practitioner's perspective. The second part of this web series will take place in December 18, where we'll take a more focused approach on values management and what are the roles of the Ministries of Health and principally in contributing to social justice. So we will registrations for that very soon, and we hope to see you there. Finally, the working paper, as we mentioned before, will be released this month. So you all have this very nice Christmas present to read during the holidays. Thank you so much for being a part of the session. We really enjoyed sharing that with us, and see you next time. Thank you.
Thank you.
Thank you.